talking about your bad back. We're stuck on the first slide. Okay, here we go. Sorry about that. So what we're going to do today is do a little introduction and background here. We're going to go through a quick anatomy of the spine, specifically low back, and then we're going to go through some myths and misconceptions, debunked, and we're going to demonstrate a few exercises for a healthy back. Okay, I'm having technical difficulties. I might have to move here. Bear with me, guys. I might have to change location. So while I'm figuring this internet issue out, I will tell you guys, I'll repeat that any questions you have, find the chat box, and I'm going to try to answer them. Whenever I can. Again, I cannot hear anybody, so use the chat box. That's where I'll see your questions. Okay, here we go. We are here at React Physical Therapy in the West Loop. My name is Jo or Johanna. I've been a physical therapist for 5 years. So I did my undergrad degree at U of I in Champaign, and then I did my doctorate in physical therapy at UIC nearby here. So we have other locations of React in Lakeshore East, Lincoln Park, Wilmette, and Deerfield. So hopefully we have some of you guys from each of those locations tuning in today. But at React, we try to treat the whole person. So that means treating the whole body, not just looking at the exact spot where you may have pain, but we're looking at trying to see what's causing that pain and how can we not only get you back to doing what you want to and need to do, but how can we get you back and stay healthy. So why are we talking about back pain? It is one of the most common ailments that people in the world, and especially in the United States, have. The numbers are around 60 to 80% of people will have some low back pain affecting them during their life. So that's almost everybody, basically. There's a very high medical cost to low back pain, whether that's getting treatments, different treatments, imaging, doctor visits, plus the time lost at work and quality of life lost. There are psychosocial aspects that can become affected, especially with chronic pain. Basically, it just has multiple variables where it's a high cost to our society. And then a big thing that made me want to do this presentation is that I hear a lot of people come in to see me who have misinformation or misconceptions about low back pain that might be kind of limiting them or actually harming their progress. All right, so our little anatomy review here. We are talking about the spine. This is a picture of the whole spine. Cervical is the neck at the top there, and then we have thoracic as a big long part where the ribs attach. And then in the bottom, the purple section here is the lumbar spine that we call the low back. And then that sits on top of this triangle-shaped fused bone called the sacrum. So that lumbar and sacrum region is what we're referring to when we talk about low back. The main movements of the lumbar spine are flexion and extension primarily, and then there's some side bending, and less so, there's also some rotation. So the spine in general also acts as a kind of base for the whole rest of the body. So like I said, the rib cage attaches, the sacrum, we'll go back here, on either side attaches to the pelvis. So at the very top of the spine, we have the head, we have the trunk and limbs, and then the bottom attaches to the pelvis, and the low back kind of transitions us to the lower body there. So obviously very important and central structure. Going back to the joints of the low back, we have a little model here as well. These bottom vertebrae here have a large vertebral body. In between those is the intervertebral joint, which we'll get into in a second. That's the large joint in between there. And then in the outer part, we also have on either side facet joints. And those are kind of responsible for providing some stability, and they're almost vertically oriented in the low back. So that causes the tendency for flexion and extension movement more so than the lateral movements in this part of the spine. So it's the orientation of those joints that kind of causes that. When we look at the intervertebral joints, the famous disc that you hear about a lot is the cushion in between those big vertebral bodies there. So the discs act as a shock absorber, even when we're doing nothing and just sitting there, or when we're moving, jumping, doing anything else. So these are made up of a ring annulus fibrosus with a nucleus pulposus on the inside, which is a more kind of jelly substance. So the two different parts each act in their own way to provide kind of like a shock absorbing mechanism. Another, on our model here and on the picture, another thing you're seeing is the nerve roots. That's the little yellow nerve roots. So the spinal cord is housed within the vertebrae, kept very safe in there. We want to keep the spinal cord safe. And then nerve roots come out in between each vertebral level here. So they come out underneath the vertebral level that they're named for. So like the L3 nerve root would come out in between, underneath the L3 vertebrae there. And these are what are responsible for what we call radicular symptoms. So that is when you have kind of pain or numbness and tingling, something like that, going down into certain parts of the leg. These are the nerve roots that can be affected, kind of leading to those symptoms. We also have a variety of different ligaments. I'm not going to get too specific here, but if you just look at all these areas where there are ligaments between these vertebrae, these are very thick, strong structures. So along the backside there as well, on the outside, along the inside, and in the spinal canal, between the different parts of the bones, there are ligaments all over, and those provide a lot of the stability, but still allow for movement as well. Muscle-wise, there are tons of muscles in the low back. The ones you can't see in this picture, there are little tiny muscles in between the parts of the bone here that help with small movements, just rotating the spine a little bit, things like that. And then we have the giant spinal extensors that extend from down at the sacrum all the way up to the head. We have quadratus lumborum, the big lat muscles, multifidi, the psoas muscles, which are hip flexors, and they actually attach from the front side. So you can't see in this picture as well. And then we have obliques, and then other abdominal muscles like the transverse abdominis. And besides these listed ones, we have other muscles that affect the low back. Really, you could argue that a lot of the muscles in the whole body can affect it in one way or another, but big ones like the glutes, the hip rotator muscles, rectus abdominis in the front, things like that as well. So basically, all this stuff that we've just looked at shows you how amazing of a structure it is. It's both very stable and strong. It has all these things stabilizing it, and it's also able to move a very good amount. So what happens when we have back pain? One question is, what happened? Like, why is there pain? And that can be different, whether it's an acute injury, so sudden, I picked up my pen and I suddenly have this pain. What the heck could have happened? Versus chronic pain, which is actually quite different in that sometimes the actual pain system is what can be causing the symptoms to continue and persist on at some point. But either way, that's something we're going to try to address through these myths here that we talk about. The other thing that we're going to try to talk about is what should we do about it? What can we do to get ourselves out of this back pain? So here we go with our myths and misconceptions. Number one, just like the title here, I have a bad back. So first of all, we just don't like to say this because it's not being nice to yourself. Our spines are, it's the only one you get, and it's not bad. We don't like to call it bad. It's not fragile. This kind of thought process or wording makes it seem like it's broken or fragile or something like that. But like we just went through, they're very resilient structures. They can heal very well. And when we think or talk in this kind of way, it can end up leading to fear of movement, which there's actually a word for that called kinesiophobia, or avoidance of movement. And we know that those things can actually end up causing worse pain, which we'll come to in a minute here. We'll touch back on that. The next one is another wording thing that I hear a lot. Let's see if this will work. Okay, never mind. This one is my back went out. So the reason that this one is a problem is because it kind of makes it seem like there is a big instability or deformity that happened. And that is almost never the case. So usually when you feel like you have a sudden back pain, everything's kind of seizing up on you and you're like, oh my gosh, I can't move very much. If somebody told you your back went out, it can induce a harmful fear. And again, like I just said, that can lead to moving less, that can lead to more pain. Actual large instabilities like that are very rare. If you have a trauma or a big accident, then maybe. So what's not happening when your back quote unquote went out is, like, you can see the model here, it's not over here. It's not over here instead. It's not shifted out of place. Anything like that is almost always not happening unless it was like a big trauma. So what is happening? So often when you get that kind of seizing up feeling like I can't move in the ways that I normally can, it's your body responding to an acute event. Oftentimes the muscles around the area, all of those many muscles that we talked about, will protectively spasm or tighten. And that's because that spinal cord's in there, right? So those muscles will just overly react and tighten just because that's their job, protect. So that doesn't mean that something structural happened, but that muscle spasm can actually make pain worse and movement less initially. So the cause of the pain can be from a variety of those structures that we talked about earlier. It could be a sprain of one of those little ligaments. It could be an irritation to the joint, those joints on either side. It could be muscle strain. Any of those, just like any other part of the body, those things can kind of cause things to get angry and inflammatory response to happen there. So disc herniation, people think, my disc popped out in this moment that I bent over and that's what's happening. But actually, disc herniation is not usually a sudden thing that happens. It's usually something kind of over time. And we'll get to this later, but it's not always even symptomatic. So moving on, the next one is I should stay in bed or move less after I hurt my back. So a very long time ago, people used to think we should rest in bed or, just only do like a traction table or something like that when my back hurts. Since then, this has been very much disproven. Many studies show worse symptoms and outcomes with the more inactive you become actually after an injury. So even though it is true that you may have pain, it's actually better to get moving. So even if it's just walking, walking is usually easy and it's always good for you in multiple ways. Walking is good as a preventative thing to prevent back pain, but it's also good if you're in kind of a moment of, I've hurt my back and it's hard to do things, but at least you can walk. Another thing that might be beneficial is to kind of test yourself out for a directional preference. And that is, with certain presentations, we see that the spine might like to bend forward more, or the spine might like to extend backward more. So if you find a motion that you find, okay, I'm able to do this one actually, and it feels fine, then use that motion and keep doing that until you can kind of start doing the other ones as well. So let me just check the chat here. No questions so far. Feel free to chime in at any point with questions. I'll check in a couple more times here. Okay. Moving on. So one more thing about getting moving. When you're, testing out what you feel like you can and can't do in those moments, it's also important to know that having pain with a movement does not mean that you've harmed something else. Again, going back to the structural thing, you haven't kind of moved something out of place. You haven't set yourself back. It's just you may need to pick a different movement for the time being until you can get back to the other ones. Okay, the next one, this is a big one here that people may not know, is I need to get an X-ray or MRI or other imaging to find out what is going on and causing my low back pain. So actually, it's not necessary in most cases. And if it is necessary, that usually, your doctor, physical therapist, and providers in general will tell you you need to get it kind of to rule out some of the bigger, scarier things, or if you're having certain symptoms. But usually, in general low back pain, it's not actually recommended. And that's for a variety of reasons. One is it's high cost. So to go to the doctor, get the prescription for the imaging, go get the imaging itself, which is an expensive thing. The costs are high. And then the information ends up often not being helpful. And that's because, for example, on an X-ray, you may find that there's arthritis or degeneration between the joints. And sometimes those are said in kind of words that you don't know, like spondylosis or degenerative joint disease and things like that. But often those are things that just do happen with age or with time, and they may or may not be causing your symptoms. So same thing with an MRI. Disc bulges have been found to be insignificantly different on an asymptomatic and a symptomatic individual. So that means that somebody who has no complaints, it took a picture of the back, and it could look the same. It could have the same disc bulge or a couple of disc bulges as somebody else who's having a lot of symptoms and issues. So that means that it isn't really helpful to get that image. The other thing is that treatment often doesn't change. So if we see, okay, it looks like this might be what's causing those symptoms that we also saw in the clinic, right, that we tested or you saw at the doctor's office, well, probably the recommendation is still to treat it conservatively first. So doing physical therapy, for example. And lastly, finding things on imaging, especially if it's, words you don't really know, it's the technical terms for them. And somebody tells you, you have this disc bulge or you have degeneration, they might actually make your symptoms worse. And this comes back to the fear avoidance and psychosocial aspect. I'm going to go back here to this diagram. I didn't show you this diagram on the last slide here. So when you have an injury, you have a pain. If you kind of don't handle the knowledge of that pain very well in terms of you're worried about it and you're fearful about it and you're avoiding activities, that makes you use your body less, makes you able to do fewer things, and can even make you feel more down. And then that kind of feeds more into the cycle because then you have more pain. All of those things contribute to pain. So anything that can contribute to fear avoidance or kind of higher levels of worry and less activity, we don't like those things. Instead, what you can do is have a clinical assessment of your symptoms. So how are you presenting? What makes it better and worse? Things like that. And then the appropriate treatment, which again is usually conservative treatment at first. All right, this one. Blank exercise is bad for my back. So there's actually no exercise or movement that is inherently bad for your back. We are amazing and we're able to move in all different directions. We can move fast or slow. We can lift heavy things. We can't all do those things at all times to the same level as other people, but we have the capacity, to do those things. We have strong, resilient backs, like we've talked about before. So there are considerations that may make it difficult for you to do a certain movement, or your current presentation might make that movement painful to you. But it's not necessarily that, for example, people should not deadlift because it's bad for your back. In fact, most exercise is good and healthy for your body, including your back. There are other considerations that often contribute to injury, including fatigue, like how tired were you? What else have you done up until that point? When did this happen in relation to other things? Nutrition, sleep and stress are really big ones. So not being rested enough. And then mobility or strength deficits. So how is the rest of your body? How is your strength? Paired with any of those other factors, kind of can create a storm where then you might get injured doing an exercise. But it's not because the exercise was wrong or like we should never do it, but it's because maybe you were set up by a few of these factors and had an injury or pain then. And if you do have pain with a certain exercise, that's a good thing to kind of bring up to a physical therapist. Speaking of which, our last myth here is spine problems are for chiropractors, other injuries or areas of the body are for physical therapy. That's just false, because I can tell you I've seen more spine or back injuries than probably any other body part personally. So we treat the spine all the time. It's in our education in the doctor program. And then also myself and most other physical therapists I know have taken continuing education kind of focused and geared towards treating low back pain. So what does it look like when you have low back pain and you do physical therapy for treatment of it? One of the most important things is a comprehensive assessment. So I like to hear a lot of information and then ask a lot of questions, because this gives us the behavior of your symptoms. And that's what's going to help kind of guide how do we get you out of the pain and get you moving and back to everything else. So that's very important, actually. And then an individualized assessment. So again, like I mentioned earlier, we are looking at the whole body and not just, what's your back range of motion right now. We're looking at what other parts may be contributing that may have led you to this point and that we need to address. And then the goals of physical therapy: to treat the symptoms, get you out of that bad pain, to treat the causes and contributing factors, provide lasting relief, and lasting relief that you can take home. So what can you do when you feel like my back's a little stiff, or I'm in an episode where I have some pain again, so that you're independent with self-relief there. And then to improve your function and participation in everything that you want to be able to do. So we use various different types of techniques for that. We address, muscles, we work on the joints. We have tools such as dry needling. I'm certified in dry needling, and several other providers are as well. Movement preferences we look at. This is through McKenzie method training, which is another of the continuing ed courses geared towards treating the spine. We strengthen, look at flexibility, look at activity modifications if needed. Basically, it just depends on the person. So ultimately, if you have low back pain and you feel like you need guidance, then see a physical therapist who can look at why you as a specific person may be having that pain. Because that's what's going to help you get on the right path. And just check we're at questions. So I'm going to check my chat box here. Does anybody have questions about what we've gone over? What parts of the body would you focus Graston on for low back pain? So you're referring to like instrument-assisted soft tissue mobilization, I believe. So if somebody were to use that for low back pain, I can't answer your question very directly because that comes back to what I just mentioned, where we look at each person individually. So if somebody wanted to use the instrument-assisted kind of Graston type of soft tissue work, they would probably choose to do it where you have deficits that clinician thinks is contributing. Like maybe if it were in your hamstring or other things like that. Okay, another question here. What can be done for a compression fracture? So in the case of a fracture, it depends on multiple variables, like how it happened, if it was chronic or if it was more acute. So oftentimes with anterior compression fractures here, so again, this is another one where it comes down to, okay, acute. So in that case, you probably had imaging and saw a doctor and everything like that. It really depends on the mechanism of injury and your presentation again. I'm sorry, I'm not answering specifically because I don't see you as a patient, but often with compression fractures, that's going to be more anterior here in the body. And again, it depends on the person. You still typically want to be moving just in specific ways that feel good to your body and to your healing at that point. The lacrosse ball exercises have been helpful for at-home exercises. Outside of that, is there a general go-to exercise that you would also like and recommend? Yes. So the next part here, we're going to go through some demonstrations. I'm going to do a couple of demonstrations for mobility exercises, getting those joints moving, and then a couple of strengthening exercises as well. So we'll get to that in just a second here. And then those lacrosse ball exercises that were just mentioned are kind of self-releases, which you can find on our React PT YouTube page. So you can go to lower body section releases, for example. Best at-home ways to increase disc space for the vertebrae of the low back. So if you're talking about disc height, so over time, the discs do narrow. It just happens. That's what happens. A lot of things happen with age, and that's typically one of them. But studies find that disc height is actually maintained better in active individuals. So to answer your question, keeping active, keeping moving, whether that be as simple as walking or whatever other type of activity, weightlifting, sport that you enjoy, it is healthier for those discs to move, to keep moving, keep loading. Tissues actually do better when they're loaded. It kind of comes back to the bed rest versus movement. Anybody else questions? Okay. I'm going to keep an eye on this here, but we will go over to do some demonstrations. And I'm going to walk this way. Checking for questions here. Taking a tour of the clinic here. So, the first exercise that we're going to do is a cat-cow. We're working on spinal mobility, flexion and extension here. So we're going to start on all fours, and we're going to go into an angry cat pose, arching everything upward, tucking your head and tailbone down. And we're going to come through to neutral, and we're going to extend the opposite way. So head and tailbone go up to the air, chest sinks towards the floor. And we're going to go smoothly between those two motions. So this is one example of an exercise where if you have a directional preference, it may feel better to go one direction or the other for you. If that's the case, then just pick that one direction. So if you're in pain, but this way feels okay, go there, back to neutral. Or vice versa with the flexion movement. So you can modify that later. I'm going to move these. Hopefully that's better. The next movement, we're going to work on rotation by doing open books. Legs can both be bent up, or if you prefer, you can put a foam roller and support your leg there. I have my arms stacked, and I'm going to open up, keeping my hips and legs where they are, but opening up with the upper body, and then closing back. So each time, I'm going to go as far as I can, and I'm looking with my gaze where my hand is going. So those are open books. Do those on each side to get some rotation range of motion there. Any questions so far? Sorry, it's dark in here. Hopefully you can see okay. Next exercise, we're going to work on some stability and multiple muscles of the upper and lower body here incorporated. We're going to do bird dogs. So you're sitting in that tabletop position here again to start. And you're going to take your opposite leg and arm and lift them away at the same time. And while you do this, you want to have a nice stable core. So you don't want to let your hips dip down either direction while you do that. That was bird dogs. Any questions here? Next, we'll flip it over, almost the opposite exactly here. And we'll start in the 90-90 hip and knees position with my arms up top here. And we're going to do deadlifts. So for this one, it's again the opposite arm and leg will move apart, and then lift back up. And then, so we want to keep the opposite leg and arm pretty still in their starting position in the meantime. To make this one easier, you can do a little bit less of a movement, a little bit less leg movement, especially there. To make it harder, you could grab a resistance band with your arms, hold there, or grab some weights and keep the arm movements. Next, we're going to do some bridges. This one is focused on strengthening of the glutes, glutes and hamstrings here. Still incorporating a little bit of core as well. Bridges are usually pretty tolerable, even if you are having some back pain. It's a good one to try. So I'm lying on my back, feet are flat on the ground, about hip width apart. I'm going to just push up, squeeze my butt, and go right there. If it feels uncomfortable, you can try a couple things. You can try engaging your core before you go up. So a little soft pull of your belly button towards your spine, not tilting too much with the pelvis, but just a soft engagement there, and then pushing up. Or you can try to adjust your foot position slightly. You might be a little bit too far or too close from you to be comfortable and feel your foot. That was bridges. The next one that we'll do is simply a squat. So you can do squats, regular squats. If that's too much, you can do a mini squat. So a mini squat, I like to say, pretend that you're going to sit onto a chair, but don't actually sit all the way down. So you're starting to sit down onto a chair, but that's all. So if it feels painful or too much to go all the way down, then just the first part of the motion for now, until you're able to do the full squat. And then another way you can do it is actually use a chair, and then it kind of turns more into a sit to stand, but it's kind of similar to a squat. So sitting in a chair towards the front of the chair, and you're gonna lean forward and push up through your heels using strong legs and butt, and then lowering back down slowly, not plopping down. Sit to stand there. So both the squat and the sit to stand engage a lot of different muscles. When people tell me I can't squat, I say, well, you can do it to some degree if you're able to sit into a chair. So if you feel like squatting is not something you can do, then sit to stand is a good option to try instead. So that was it for our demonstrations here. Anybody have last questions, either about those or about anything we talked about in general? Thank you. Thank you, everybody, for joining. I hope you learned something, information, or something to try at home. Appreciate you joining me tonight. If you have any more questions, I'll hang out on here for a couple more minutes and try to answer them. And also, my email is jdiamond@breact.com. If you have specific questions, you can always email me there. Thank you. Thanks, everybody.